Good morning, and thank you to Professor Mary McCarran from the Trinity Centre for Ageing and Intellectual Disability, and to Dr. Kathy Payne from the All-Ireland Institute of Hospice and Palliative Care for facilitating AIIHPC to share this information this morning. We're aware that there's a lot of guidance out there for disability settings, and it can be hard to interpret and to apply in a disability setting. We have set up an infection prevention control hub to help support and advise providers of services and people who work in settings. So since setting up that, even in the last week, we've had a huge amount of queries and questions that have come in specifically about infection prevention control and the use of PPE. So we're hoping that we can use that information today to help you and to help you use it practically in your centres. So I'm going to share the presentation. Okay, so since the beginning of this public health emergency, we've all had to, all of our organisations have had to change the way we operate and the way we work. And one of the ways we have responded in AIIHPC is providing an information source through the Infection Prevention Control Hub. We're recognising that people are working very hard to support people who are living in residential settings and availing of other services. And we realise that people do have a need for support and in implementing the guidance on infection prevention control. Just as a note, just to point out that this presentation refers to the guidance, the national guidance as it applies in the Republic of Ireland. We're aware that there are other people logging in from outside of Ireland, but just to make that note. And also to note that the guidance is being updated very regularly, and that it's important for people to check for updates on www.AIIHPC.ie and to monitor that closely for changes. Just in relation to the role of the regulator, as I said at the outset, we have had to change the way we do our business. As providers of services will be aware, routine inspections are not going ahead, for example, and there have been other changes to the way we monitor services. However, our priority is the health and the well-being of people using services. We want to support providers who are responsible for delivering those services, and to support the staff who are working on the ground in delivering those services, so that they can feel confident and in the care that they're giving. In response, as I said, we've set up the AIIHPC Infection Prevention Control Hub. It's staffed by inspectors who have experience in infection prevention control, and we encourage people to use it as questions arise in their particular settings or their particular services, and they grapple with the various challenges of implementing the guidelines in their particular service. I'll put these details up again at the end of the presentation, but just to encourage people to take note of them and to call us if we can provide help and support. Just to give a very brief outline of the type of disability settings, the profile of disability settings and residential services that we have in Ireland, and just to note that there are almost 1,300 of those centres now, and they vary widely in their makeup and their size and their distribution. So much of the guidance is aimed sometimes at clinical settings, and it can be difficult to interpret how it should be applied in, say, a smaller service for 3, 4, 5 people located out in the community. And a lot of the questions that we're getting have been around what good infection prevention control looks like in some of these settings, which are diverse. And also to point out that there still are a number of people who live in maybe campus settings or in larger houses for 10 people or more. And again, that can present some people with challenges in how they apply the different pieces of guidance. Again, just to briefly point out that the disability sector has made huge progress in the types of accommodation that is now provided to people in the community. The majority of people live in smaller settings now. The majority of people, in fact, live in settings for perhaps 1 to 8 people. This is a reflection of the huge progress that has been made in decongregating larger settings. And in the current pandemic that we're living through, this is a strength in the sense that people are living in smaller units, and this reduces the risk, it reduces the number of contacts, it reduces the number of the opportunities for a virus to be spread within a residential care facility. But just to point out that there are still some people who are living in larger settings, and again, that presents its own challenges in terms of a higher physical contact unit. In terms of the population, just to point out that having a disability in and of itself is not a risk factor. However, as Professor McCarran has pointed out in previous webinars, you know, the general people with multimorbidities are at a higher risk. People with a disability sometimes may have higher levels of comorbidities or multimorbidities, and that places them at a higher risk in terms of acquiring maybe the virus or in the impact that it may have on them. It's important to point out the psychological impact as well that this is having in terms of the messaging, in terms of the restrictions that might be in place, in terms of the isolation measures that might be in place, and the impact that that's having on people who may have emotional or mental health conditions, and the impact of certain restrictions that that's having on people. It's also in considering the guidance that's out there to point out again that the accommodation that is provided in congregate settings there still are a number of people who share bedroom accommodation, and that presents its own challenges in terms of IPC. And again, in terms of some of the settings, regular or routine access to IPC advice is not something that people may have or may be used to. The main guidance that we will refer to and that applies in the disability settings is as we see there on the screen from the Health Protection and Surveillance Centre, and we encourage people to access this regularly, to note that the guidance is being updated regularly, and people should check it regularly for the most up-to-date advice. In terms of the regulations and our role as a regulator, we need to point out that the regulations still apply, and that when people are considering their arrangements in centres for protecting people, that they need to consider the regulations for premises, for governance and management, for risk management, and obviously regulation for 2027 for the protection against infection. All of these regulations and their associated standards provide a framework for ensuring that centres can be as prepared as possible to keep this infection out of their centres and to be best placed to manage it in the event that a centre does have a case of infection. Closely aligned to Regulation 27 are the national standards for infection prevention and control in community services. We appreciate that this may not be the first document that people go to in a pandemic situation. However, many of us have told, or many of you have told us that you are reviewing at the organization level your capacity to respond to infection risks, your capacity to implement infection controls, and your capacity to respond in the event that you have cases. So these standards very much provide you, when you are looking at that capacity and looking at your organizational capacity, they provide you with a framework to assess what your capabilities are and how you can respond. And as I said, a lot of you have told us that you are now reviewing that from, very much from the ground up. Again, to be aware that the Chief Inspector has issued directly to providers a number of communications specifically in relation to the current pandemic. And one of the key ones there is the communication in relation to contingency planning. So the Chief Inspector has urged people to review their contingency plans and to make sure that they are best placed to keep this virus out of their centres and to be in a position to respond in the event that they do have positive cases. So the Chief Inspector has urged people to consider their contingency arrangements under governance and management. For example, of those almost 1,300 centres, there are a relatively small number of providers. So it's very important that those providers have structures in place to stay in contact with the many centres that they may have distributed throughout the country, to ensure that they have the resources that they need, to ensure that they're getting the communication that they need, and to ensure that their staff are informed and that those providers are assured about what's going on in all of their centres. It's very important for providers also to look at their staffing arrangements, again recognising the very diverse staffing arrangements that are in place throughout the disability sector, from nurse-led services to services which are very much social care settings which would not have ready access to nursing, which may not have ready access to nursing input. And again, obviously, to look at the infection control measures, and the Chief Inspector has set out various headings there for people to look at and to ensure that they have appropriate resources in place. And we'll deal with some of those now in more detail. Our key message from AIIHPC is to keep this virus out of centres so that residents are protected. And where you do have a case, that you can be best placed to respond and prevent its spread to other people who are using services. So obviously, in looking at preparedness, providers will be looking at their policies, procedures and guidelines and making sure that they're disseminated appropriately to people and people are aware of them as they're being updated. Contact details are very important at this time. Many centres will not be used to having frequent contact with public health, for example, but it's important that they have those details at the ready and they start to make contact in the event that they have any concerns. Again, contact details for escalation for 24/7 is extremely important, and it's very important that people have those at the ready at all times of the day and night. And we'll emphasize later on the importance of making contact extremely early in the event that people have suspicions or have concerns about deteriorating conditions in residence. It's important that people identify isolation facilities. It's important, as I said at the outset, that many of our disability centres now are smaller units for smaller groupings of people, and that very much is a strength in that these units can operate as discrete, independent units. In addition to that, some people may be looking at their services and they may be identifying that they need more space, that they need more isolation, single rooms. And again, AIIHPC has written out to the providers and provided a pathway for them to do that, and to do that in a very quick and an urgent way if they need to do so, which doesn't require the usual application and application process that goes with that. And this is all done where there is an emergency situation or where residents are at risk and providers need to access safe accommodation for residents. Again, in looking at the preparedness, training education is key, and the importance of regular briefings and information for our staff. And to include all of the staff in the centre, including ancillary staff, people who may be involved in catering, in cleaning, in maintenance, and to make sure that any staff member who is entering the service is fully aware and fully updated on the various pieces of infection control training that people should be doing at the moment. Monitoring of staff for symptoms is now something that you are telling us, providers are telling us that you are now widely doing, that you're having check-ins with everybody at the start of each shift, that temperature monitoring is taking place, and that staff are very aware of the need to inform management as soon as they notice any change or symptoms that might suggest that they should not be at work. And highlighting the importance of standard precautions, re-emphasizing, reiterating, and really highlighting to people that these are the things that will keep the virus out of your centre. Hand hygiene, respiratory hygiene, cough etiquette, and really increased and improved an attention to environmental hygiene, to cleaning and disinfection in the appropriate way. These are the kind of things that will keep the virus out of your centres and keep residents protected. We really cannot emphasize enough the importance of the standard precautions, of things that maybe we've been taking for granted prior to this, but the importance, for example, of making sure that cleaning is done appropriately, disinfection is done appropriately, that people are looking at the kind of products that they're using for cleaning and disinfection, and that they are using them as per the manufacturer's guidelines, and that they understand that if they're using a separate detergent and disinfectant, for example, that they're actually using those appropriately, they're using those two steps, and they're allowing appropriate contact time after using a detergent to allow a disinfectant to have effect. In looking at preparedness and keeping this virus out of your centres, it's important to identify your high-risk populations and to ensure that they're protected, and to look at the spaces available, to look practically at your centres and see what spaces can be used, what rooms can potentially be converted into a safe, appropriate bedroom accommodation for people. As we know, and it has been highlighted, single bedrooms with ensuite facilities are the best way possible in terms of managing this situation. And again, for providers to look and identify their higher risk people who may have comorbidities and may be particularly vulnerable at this time. There's a need to educate staff on the early signs of this disease and to be very vigilant for atypical presentation. So at this stage, people are very aware to look out for the shortness of breath, for the new cough, for the spike in temperature. But what people have told us and what we have seen so far is that oftentimes infection is starting with symptoms which are atypical, perhaps changes in behavior, loss in appetite, and those kind of things, which staff need to be aware of. And to be aware that they must report and must act on quickly and report and ensure that the testing takes place as early as possible. There needs to be an emphasis on the need for unwell staff to stay away from work. Again, like many clinical settings and disability settings, people feel that they're doing the right thing, perhaps by showing up for work when they feel unwell. This is not the case in this situation. If people feel unwell and have symptoms of this disease, they need to stay out of their centres, they need to contact their managers, and they need to have that discussion at the earliest possible time. People need to implement a low threshold of suspicion. So looking at the atypical presentation, people know that the residents and the people that they're working with on a daily basis, they know when they're starting to change their behaviour or changing in their presentation, and they need to highlight that to the person in charge or to the persons involved in management at the earliest possible stage. As we said, this will facilitate testing at the earliest possible stage. And again, as Professor McCarran has highlighted in previous webinars, there is a huge urgency about the results in disability settings and recognising the impact that awaiting results and maybe awaiting in isolation for these results and the impact that has on people, on their daily routine and on their overall well-being. We need to be, centres and staff need to be wary of a result of not detected. Previous information and webinars have addressed that, unless the test is carried out appropriately, a result of not detected may come back. However, the person may in fact be carrying the virus. So it's about still being practical, observing the resident, observing their presentation, and risk assessing what's in front of you. Restriction of movement within the centre is obviously very important. And, as we say, a number of the centres now are divided into smaller units. It's important that people look at how they can cohort their residents and their staff together. So it's important that, that if staff are coming into the centre, that if at all possible, we can cohort them so that they can work with the smallest group of residents possible, so that they are not moving from house to house, from unit to unit, and potentially carrying or being a source of infection. This is also important where, for example, you identify and you have an identified confirmed case of COVID in your centre. It would be very important to identify what staff have been in contact with a confirmed case in order to identify if they have been a close contact. And if they have been identified as a close contact, they may have to be excluded from work for a period of up to 14 days. So the more we can cohort residents and staff working with them together, the less impact this will have in the event that you do have a confirmed case. Also, there's guidance out there for arrangements for transfers back from acute settings, back from hospitals, and how that is managed with single occupancy rooms and close monitoring of the residents. And it's important that people are aware of that. At this stage, people will have reviewed their visiting arrangements, and you have providers and staff have been telling us how they have been doing that, and this has been very challenging, and we're aware of that. However, there does need to be particular consideration given to visiting arrangements and how that is managed at end of life. Okay, so management of an index case or a suspect case. Most centres are doing extremely well and really are doing a great job of keeping this virus out of their centres. However, it may come to the situation where a confirmed case does arrive in a centre, and people need to be in a position to respond to that and make sure that it doesn't spread any further. So in the event that you do get a result of positive back for residents, it's important to identify the vulnerable cohort of residents. It's important to carry out a risk assessment of that particular situation and how that person will be accommodated and who has been in contact with them. It's important to look at your available resources of staff to access how you're going to access your medical advice regularly, how you're going to use your accommodation facilities, your medical supplies, your medication, your chain of supply for PPE. Communication is vital. It's vital that the HSE and public health in particular are informed as soon as possible. So the importance again of having those details ready to hand so that public health are updated. The importance again of communication with residents and families and your staff team. And again, ensuring that a notification is submitted to HIHPC. I suppose when we look at communication, it's really key, and this is something that's come back as well through the information through the Advice Hub, is that people really crave this information. They need to know that what providers are doing to keep their residents safe, and giving people good information, effective information, so that they're assured is really important at this time. Isolation in a single room with ensuite bathing and toilet facilities is key. However, this may not be possible in some of the larger congregated settings. In that situation, people need to risk assess it, look at what rooms they have available. At the moment, the advice and guidelines would be that cohorted people who are confirmed positive may be cohorted together in the same room. However, other people should be provided with separate accommodation. And we would advise that if you do have a specific query about that this should be done with cohorting and the management of multi-occupancy rooms, that you address that with your public health, or by all means, please contact the hub as well. For your case, confirmed case of COVID, it's important that the room is maintained very clean, and that infection prevention, environmental hygiene precautions are ramped up, and that the door to the room is closed, it's well ventilated, and that people are aware of the precautions that must be used. It's important that the correct PPE is available, and that people are shown how to use that properly and they understand when to use it. It's important that distancing is implemented, and again, protecting staff so that they don't become unnecessarily close contacts and perhaps need to stay away from work, so that they're using the appropriate PPE, that they're maintaining appropriate distance, and for the shortest time possible. Many people have asked us as well in situations about maintaining distance, and that some residents may present, for example, with drooling or productive behaviour which results in coming into contact with saliva. And people have asked us how they maintain distance at that point. So we would say that people need to look at their situation individually, look at the space available to them. Have they got a space that they can use during the day? Have they got dedicated staff that they can allocate to this setting? And can they provide them with the appropriate PPE, including masks, and that they need to increase their cleaning and disinfection in that situation. Monitoring of residents during this time is extremely important. So if you have a confirmed case, it's important that you really ramp up and increase your monitoring of other residents, and again, be vigilant and aware of those changes in presentation. And again, we've mentioned that many providers have already implemented their monitoring of staff and their requirements for staff to report to them if they have any symptoms. In the event that you do have more than one case, it may be that a centre has to move to an outbreak situation, and an outbreak really is defined as when there is spread within a centre. So it's not cases that have been transferred into a centre or being admitted into a centre. It's evidence of spread within the centre. This situation will be managed in close cooperation with your local public health department. They must be notified at the earliest possible stage, and they will usually convene a multidisciplinary outbreak control team, or OCT. It's important that close contacts are identified and followed up with. It's important that cohorting arrangements are implemented, and that there are dedicated staff who work only with people who have positive confirmation of the virus. It's important that residents avoid communal areas for 14 days from the onset and 5 days post-fever. Residents are encouraged to carry out hygiene, and again, there's a lot of information out there now, including social stories, including visual aids that people are encouraged to help people with this, and also encouraged to use with residents to help them understand the need for PPE and to desensitize people to a lot of people perhaps wearing PPE that wouldn't have been wearing it before. It's important to retrain staff in the use and reiterate the important and safe use of the PPE. We've had a lot of queries into the Infection Control Hub about the use of PPE and how it should be appropriately used and what should be available at different times. In the last day or so, the HSE have updated guidance and published updated guidance in relation to PPE specifically for disability settings. So we'd urge people to go and look at that closely. The type of PPE that should be used will vary from setting to setting and will vary depending on the COVID status of the resident, the type of room that they're going into, the type of activity that they are carrying out, and whether that activity is very close activity with the resident for a prolonged period of time. That then will dictate whether masks are required in that situation and what kind of gloves, apron, gown, or eye protection are particularly required, depending again on the type of activity and the length of duration that will be carried out for. The principle with the use of PPE at the moment obviously is that there is informed use to ensure supplies are available to all. So we're referring people to the guidance on HPSC and HSE as I've outlined, particularly now for DCD settings. And we're making people aware that inappropriate use can actually increase the risk of infection. So, you know, particularly around the use of masks, there are a lot of queries coming in relation to that. And really the advice is to follow the guidelines closely. The inappropriate or prolonged use of masks, including touching of them, taking them on and off, actually increases the risk of infection, and this should be avoided. And really people should only use them as it's set out in the guidance. Standard precautions are always required and where there are risks of blood and bodily fluid exposure, and they should be continued and emphasized. The importance of good hand washing is really, really important. Cannot be emphasized enough at this time. And obviously PPE use will be required where there is close contact and carrying out supportive activities with confirmed or suspected cases of COVID. As I pointed out, universal use of PPE with asymptomatic residents is not currently recommended by the guidance. However, that said, people must be vigilant of atypical signs, and they need to risk assess situations where they believe that there may be a risk, and they may need to adopt or use a certain PPE at earlier stages. PPE is not required where there is no direct contact. And universal or continued use of masks increases, as we say, the risk of infection. Similarly, the inappropriate use of gloves also increases the risk of infection, and sometimes it gives people a false sense of security. And gloves must be used as per the training and guidance that's there on hse.ie and HPSC, and that just to be aware that they do need to be changed frequently, and they're only effective when used in conjunction with good hand hygiene. In relation to cocooning, we recognise that it will be necessary for some residents to be isolated in their rooms and to keep away from other people as much as possible. However, we need to be cognizant that this is the resident's home, and their rights and their freedoms must be respected. And how we do that is extremely important. And previous webinars again have addressed in really good detail about how we can ease the burden of restriction on people and how we can make those rooms and the centres more therapeutic at those times, to support residents to use technology, to use FaceTime, to use the technology we're using now to make sure that residents stay connected and they can call for help, assistance, get in contact whenever they need to. So we really would urge people to look at that information and to see how they're managing those situations. The arrangements must be assessed in the context of the residents' overall welfare, recognising the impact this can have on people. Group activities should be suspended, or recognising the need for people to maintain people's welfare. Some social groups or small groups may still take place, especially in smaller settings where people are asymptomatic and where social distancing can be implemented. Again, encouraging good hand hygiene and cough etiquette. And as I say, there are previous resources in there up there about how to maintain a therapeutic environment while this is going on. Again, just to be mindful of the end of life requirements at this time, and to ensure that you know, that there will be situations where people do need to access somebody who is at end of life, and that these must be handled in a very sensitive, controlled way. People need to be pragmatic and respectful. Visitors should be shown in and out of the centre, restrict their movement, and obviously show them how to use good PPE. Residents' rights are important. The regulations in relation to residents' rights are still in place, and we still need to be mindful of the need to ensure there's good social care, good recreational care for people. The onus is on providers and staff to maintain through all these restrictions, to maintain good standards, and to be inventive and about how we do that. I've highlighted earlier the importance of good communication with residents and families, the importance of using the social stories and the material and the visual material that is out there, and making the importance of ensuring that isolation spaces are therapeutic. Again, at this time, to recognise that people, as we've seen in the media, the whole general population, there's an increase in vulnerability. There's an increase in domestic violence, perhaps an increase in calls to various childline facilities. So people need to be aware that this is a time of increased vulnerability for all. The regulations and standards in safeguarding are key, and that we need to be careful that restrictions are not used disproportionately to restrict people's rights, and we need to be vigilant for the unauthorized use of restrictive practices during this time, and to be aware of the psychological impact that some of the restrictions may be having on people. So just to thank you for listening, again, to re-emphasize the details there and the contact that people can make, and thank you for listening, and I'll hand back now to Professor McCarran.